Hi, my name is Andrea Taylor. I'm the president and founder of A Twist of Fate for arterial tortuosity syndrome. And I'm coming to you with our team today to talk about ophthalmology challenges in connective tissue disorders. And this is part of our CONNECT program.
Ahmed Pindong, my background is a PhD in neuroscience, and then I joined pharmaceutical industry in neuropharmacology and metabolic disorders. Then I switched to rare disease, and I'm now the chief scientific officer of Cure VCP disease, which is in neurodegeneration, nothing to do with ophthalmology. So I will try to orientate the discussion, but the place is of the experts, the doctors, and the patients, mainly talking about the challenges in ophthalmology encountering different connective tissue disorders. Dr. Jefferson Doyle, if you might introduce yourself.
Certainly. Good evening, everyone. Jefferson Doyle. I am a clinician scientist at the Wilmer Eye Institute at Johns Hopkins. I am a fellowship-trained pediatric ophthalmologist, and I run a genetic eye disease clinic at Wilmer. And I run a translational research lab that focuses on understanding the mechanisms and new therapeutic options for different genetic eye disorders. My clinic we see a significant number of Marfan patients, probably more than any others, but we also see some Loeys-Dietz patients and a range of other genetic disorders.
Dr. Warner?
Right. I'm David Warner. I'm a fellowship-trained cornea specialist at the University of Arkansas for medical sciences. And I had the privilege of taking care of Andrea's son, Aiden, and he was the first person that I ever met with ATS. And that sparked my interest in this very, very interesting connective tissue disorder. I'm a cornea transplant surgeon, and this disease is of particular interest to me because I know that several of these youngsters might end up needing corneal cross-linking or corneal transplants. And so I'm happy to collaborate with this group.
Dr. Kirchner?
Yeah, I'm Rachel Kuchti. I'm with Vanderbilt University. I'm a glaucoma fellowship trained clinician scientist. I've been with Vanderbilt for up to close to 18 years, coming up there soon. I did my both ophthalmology residency and the fellowship glaucoma fellowship training at Cleveland Clinic. As I said, I am clinician scientist. We do see Marfan patients, and we do see the higher prevalence of glaucoma in Marfan patients. So that's why I have the scientific interest in this field. And I do have NIH-funded laboratory studying glaucoma using some connective tissue disease mouse models to study glaucoma. For that reason, I think that's part of the reason I got on the Marfan Foundation professional board advisory board, and I think that's how I got connected with this group. I do see Marfan patients, some other connective tissue disease patients. I just read Andrea's email. Many syndromes that I have no idea. I haven't seen any. Like I think I just overheard a little bit the Malin syndrome. I never seen a patient like this. It's apparently a very rare disease. I got a chance to read Dr. Warner's paper. I haven't seen any patients with arterial tortuosity syndrome yet. So hopefully we learn from the group.
Jade, go ahead.
Hi, my name is Jade Day, and I'm the VP of A Twist of Fate. I'm the X-linked carrier of a variant on MED12, and my oldest son is 15, and he has FG1 syndrome. He has CVI, he has a lack of peripheral fields, he has nearsightedness, visual clutter, multiple issues, and he's missing the corpus callosum in his brain. We think that's part of his CVI issues. We're not 100% because his disorder is in that nano rare category. Thank you all for joining us.
Sky?
Hello, my name is Sky Collins. I also serve on the board of A Twist of Fate, and my daughter was diagnosed in 2021 with a different rare disease called Malon syndrome. It's a variant on the NF1X gene. And when we talk about vision issues, the patients with Malon syndrome have, there is quite a high percentage of optic nerve atrophy, optic nerve hypoplasia, misalignment of the eyes, poor depth perception, visual field loss, and CVI. Our daughter is extremely nearsighted with strabismus, as well as hitting a 1 on the CVI range for processing visual clutter.
Thank you. So the goal of our project is called CONECT, so for cardiology and ophthalmology in connective tissue disorders. We are grantees from PCORI grants, and we are our goal is to prepare the conditions for establishing new patient-centered comparative effectiveness research, which is a language proper to PCORI, meaning that we try to identify everything so that we can compare two applications or two ways, two treatments in a disease. And what we try to do with this project is to identify across the diseases commonalities so that we can be stronger with different connective tissue disorders in cardiology and ophthalmology. There are two different aspects of the project. The first one is the education for a better description and understanding of the symptoms. So an education from the patient part and education from the clinician's part. The second part is identify roadblocks and technical challenges common to most connective tissue disorders, and focusing on cardiovascular and ocular manifestations. So today's workshop is on ocular manifestations. The agenda is really, I would like you to discuss and try to identify the main challenges and opportunity that we can work on and that need to be maybe triggering new research and new areas of comparison of techniques or comparison of treatments in so I choose mainly keratoconus and keratoglobus, but that can be also in glaucoma. But I don't know if glaucoma is really over cross disease in the different connective tissue disorders. So just to have a starting point, I prepared these slides, but I think you are the expert and you know better than me what would be the main challenges or the main issues we should work on for the management of corneal ectasia, or more precisely in connective tissue disorders. I would like to have maybe a round table going through all your opinions. Dr. Doyle, do you want to start with your comments on what would be the roadblocks for management of corneal ectasia?
I think, honestly, I would say, depending on, as we hit each topic, probably each of us with our relative expertise makes most sense. I would honestly say, I bet Dr. Warner could give a far more educated response on this. And I'm happy to chip in anything addition, but I would honestly start with him for the cornea stuff.
Okay.
Well, I'm happy
as long as it's not putting you on the spot.
It's okay. I'm happy to speak to my experience. So several years ago, Andrea decided to start this nonprofit, A Twist of Fate, to try to bring together families of ATS patients so that we could establish a clinic, collect data, and really characterize this disorder in a new way. And what she did really is a model for all rare diseases, because the truth is it's very hard to do deep phenotyping and come up with best practices when you have so few patients and they're scattered all across the country or all across the world. And so we actually had the opportunity here in Little Rock to have a couple of clinics where several ATS patients came And we were able to collect data about the ophthalmologic findings, and then we published that. And we found that 100% of the patients that we looked at, for example, were myopic, which previously had not been described. Very simple observation, but important for patients and families to understand. We found that a significant percentage of them had corneal ectasia, but that these ectatic disorders were different. Some had a variant of keratoglobus, others had a variant of keratoconus, others had no ectasia at all. And so one of the big challenges was simply the heterogeneity in the presentation of our patients. They were in some ways similar and in other ways very dissimilar. And there were barriers to bringing everyone together. Of course, the financial burden of the travel made it difficult, I would say even prohibitive for some of the patients to come to the clinic. So that's one of the big issues, is when you have a few clinicians or scientists who are interested in studying it, but they don't have ready access to the population that they want to study because of the logistics of bringing everyone together, it does present a significant challenge.
So you would say that the main challenge was, in fact, access to the patients.
Yes. So we
get the natural history study. Yeah.
We were able to have two clinics in which several of these patients came multiple times to each clinic. However, it became clear that in order to establish any kind of longitudinal follow-up, then we would need to have a long-term relationship with the same individuals, and that presented a significant challenge.
So you would access the first thing on identification and having the possibility of longitudinal natural history study, and not just one point, but really getting in time over years.
Absolutely. If you could establish one center, for example, where patients with rare disorders always came, and where they could have their genetic testing, where they could have their deep phenotyping, where they could have their standardized examinations, and where their disorders could be characterized and treated according to the PCQRI methodology, it would be ideal.
Yeah, it's remarkable that the cardiologists had, in fact, the same preoccupation about patient identification, and really getting the longitudinal natural history study done over several years. So it's something that should be done not only in ophthalmology, but in different manifestation of the CTD patients. The other participants, what do you think would be besides the identification that Dr. Warner noticed, do you have any other obvious roadblock to the management and the research on keratoconus or keratoglobus?
So if I may jump in, this is Rachel Kuchti. Just listening to what Dr. Warner was saying, I echo what he just alluded, pretty much everything. And I want to point out that this is, I think the biggest challenge is that it's such a rare disease. We label ourselves as experts on many diseases I never even heard of, never seen a single patient. Marfan probably is the most common condition, and sometimes it can be misdiagnosed, can be mismanaged by ophthalmologists as well. So I think we, all three of us, are in the major medical centers, academic academic centers. So we do have the colleagues have the pretty robust research programs in each center. If you just think that you are in the, we don't have to talk about the rural area, just in the private practice, probably many ophthalmologists have no idea about the diseases. You can easily miss those. At Vanderbilt, I think there are two things I want to just point out. At Vanderbilt, we have a really tremendous resource called the Undiagnosed Disease Network. It's founded by NIH. That many diseases we just have no name for, and we can refer those patients to that center, do the deep phenotyping dive, and collaboratively with the different disciplines to come up with the diagnosis using the genomic resources. Another thing I was just thinking that I think NIH have this genetic eye disease resources. Jeff, you may correct me if I think you're fairly close to NIH, and you might have even used that resource. That for the you can deposit the case to the NIH site, and I think many expenses can be paid through the NIH funding mechanism. I may be wrong, so those are the things I think. Since Andre just mentioned something about the grant, I have no idea that you already have the grant to study those diseases. So I think just the more we know, the better off for everyone. And Dr. Warner's idea is to have a center that have collective resource and have some clinicians such as us to be on board, educate clinicians to come up with a proper diagnosis.
So I would like to ask.
Sorry. Go ahead.
Oh, I'm sorry. I would like to ask, is there, so I work with Dr. Shane Morris a lot at Texas Children's. She's a connective tissue cardiologist, and she and her team started the Clarity Project, which I'm very grateful to be a part of, but we work with connective tissue cardiologists across the United States and the globe. And they are doing, they are collecting scans and doing sort of a natural history study on these connective tissue disorders. Is there anything in the ophthalmology world for these rare connective tissue disorders? Any full databases that you know of? Because we actually did go to NIH, and that's a great idea. And we could even push for them to house something like this. But when we went, they told us, unfortunately, there wasn't anything that they could tell us for ATS that Dr. Warner basically had seen the most and knew the most at this point about ATS. So I know that it was very discouraging for us, thinking that we would go to NIH and get answers. But if there is not a database, kind of like Dr. Morris had started with CONECT or Clarity, is that something that we should consider starting for the ophthalmology aspect of rare connective tissue disorders?
So if I can maybe offer a thought, that actually ties in with the point that I was going to make, I think, on this slide about keratoconus, but more broadly with connective tissue. If, for example, we take a Marfan patient, so at least what we're told in training is that keratoconus occurs more commonly in Marfan syndrome. I would be curious to know Dr. Warner's experience of how many Marfan patients with keratoconus have come to him. But at least in the several hundred that we have in our database at Hopkins, I don't recall the last time I saw one that had true keratoconus. They have corneal thinning and certain other features that are atypical, but not that I've really seen that's progressive. So we have been thinking about for a little while and starting to put into place an outcomes network, a clinical outcomes network, for example, for Marfan syndrome. And we were going to approach the Marfan Foundation about this, but perhaps it makes sense to think about the bigger picture and include other things as well, as an ocular outcomes network to really address some of these questions for, does it occur and what is the true percentage? Because if it only occurs in 1 to 2% of a rare disorder, depending on how rare that disorder is, it can be very hard to really gauge numbers. I think another significant thing that we had found with regards to thinking about this database, or depending on how broadly you want to think about it, is I banged my head against a wall for several years trying to figure out how to get eye tissue of patients with the disorders that I wanted to look at. And I was very jealous of my cardiology colleagues because, unfortunately, for patients that have, aortic aneurysm or other features where the aorta is removed, that gives access to patient tissues to do analyses. But in the eyes, most of the time you don't take it out. Perhaps a corneal transplant that may give you some tissue, but for many of the structures in the eye that we want to look at to try and understand, we don't have access until the patient passes away. And it's at least I found, if others know differently, I would be delighted to hear, but I found that it's very difficult arranging the acquisition of ocular tissues at the time of autopsy from a logistical and a financial point of view, despite our dogged efforts, and most of the time despite patients' willingness to really want to donate them to try and help with research. We had even met with an organization that is in this area to try and discuss a way that may be feasible. And they had talked about an NIH funding source as an approach to go. So that may be another area we want to explore, as the CTD community might want to consider as a group rather than tackling it individually. And I'm happy to share that information as well.
Okay. So, in fact, you would be willing to have a better standardization of the diagnose and get an agreement on the diagnostic and description for Marfan, but also the others, and create a database. I'm trying to summarize everything. And your next issue would be a biobank for the different.
Yeah, I think if we could
get different disease, sorry.
I think if we could get whole eyes, rather than just piecemeal parts that we cut out, that would be a potential significant use as well.
So would you be willing to have more research on 3D organoid models?
Certainly, I'm absolutely not averse to that. Yeah. Depending on, so for example, an area of research we work on is understanding pathological myopia. So understanding why eyeballs grow too much in many connective tissue disorders and the problems that leads to. But to mechanistically understand that, people can't even really agree on what tissues in the eye really drive it. And so an organoid is limited in that sense if one wants to try and differentiate cell lineages into multiple different structures. So perhaps with the glaucoma or the cornea, it may be a little more doable if one can get tissue. So perhaps that's just our problem rather than all researchers' problem in the CTD area. But that's certainly something we've been trying to address and banging our head against a wall. So it may make sense to do it as a group.
I appreciate Dr. Doyle's bringing up the idea of a biobank, because Andrea and I have had this very conversation that we need to find a way to harvest and store and analyze the corneas and other tissues from deceased CTD patients, because this will give us insight that we otherwise would not have. And I think you've rightly pointed out the biggest barrier is sometimes just the logistics of doing that. I think the cost portion is probably less significant than just probably the educational piece, to make sure that all patient families are unified behind this, so that we have someone to oversee the process and ensure that it occurs wherever it occurs.
So going on the tools for research, so an organoid model, biobank, what about the animal models? do you think there is a need in animal models for ophthalmology? Because that's different.
I don't think there's an animal model that adequately simulates ATS, for example. I know several people, including Bert Calwert, have tried for years to have mouse models that would simulate the condition, but the biochemistry between mice and humans is too dissimilar. And so I know that this is an area of interest, and it seems like a reasonable thing to do, but every group I know of that has tried it has not come up with a sustainable model that's truly comparable. And so I would favor working with the actual tissue as opposed to trying to create a knockout gene animal model that may or may not be biosimilar.
Well, I think Andrea has good news about ATS animal models.
Dr. Critchley, do you want
I
to?
don't know if I can disclose that, but maybe the future will change very soon. And what about with Marfan? And I think in glaucoma there are mouse models for glaucoma, no? Or am I mistaken?
We do have a glaucoma model, mouse model for glaucoma. Many models are there, but none of those, as Dr. Warner pointed out, they're just striking difference. Anatomically, actually fairly similar between human and mice, but physiologically and the tissue-tissue interaction, cell-cell interaction can be quite different between mice and the human. But nonetheless, I think we should just take what we have, a lot of things we don't know until you try. A lot of existing tools are already there. For instance, I got into the field through the collaboration with the cardiologist. The models were already there. They have been studied for years, decades by the cardiologist. Nobody just even look at the eyes, so to speak, or rarely published. So I think that's a great resource. Things are already there. We need to tap in those resources. And I think just encourage the collaboration, especially with the cardiology colleagues. I think they are a little bit more advanced. As Jeff mentioned, they have easy access to tissue. They do the aortic surgery. They get, bank the tissue. The eyes are difficult. I think sometimes we just have to go get a piecemeal, using piecemeal approach. If you do the cornea transplant, you get, the cornea banked, and now people are more and more acceptable to for instance, like my colleagues is doing the aqueous humor tab and also vitreous sample tab in the diabetic patients. Those are the patients that come in for the eye exam. They are willing to give their samples to just have the ophthalmologist to tap their samples to bank this. So they are more and more open to the ideas to contribute to science. And I think we need to have a better database, kind of harmonized database to collect the data. I think, yeah. I don't know if a center is truly, maybe it's a good idea just to develop some database distributed to the different clinicians to kind of banking the patient population for the longitudinal study, follow those patients down the road.
If I can offer just to be, I guess, devil's advocate. So I actually did my PhD in connective tissue disease cardiovascular research, really with the goal of understanding what the cardiologists were doing and knew and really translating it to ophthalmology. And so even my lab now still continues to do some cardiovascular work in addition to our main focus on the eyes. And I think the deep phenotyping that we've been doing, for example, on a mouse model of Marfan syndrome, it shows multiple features that patients show. It shows a thinner cornea, it shows a deeper anterior segment, it shows a different pupillary responses, it shows increased axial length, it shows axial myopia. So there are anatomical differences with the mice, as everyone here knows. You know, they have a proportionally much larger lens, as well as some other features. But at least some of the basic characteristics we've really now established that it recapitulates the human phenotype quite reasonably. What we also learned, and this was from my experience in the cardiovascular field, was that we did one study where we had a very, very mild mouse model of Marfan syndrome, to the point that it was present, but it was really underwhelming. You would have said it's at the most mild end of the human spectrum, and a challenge to really do, advanced progressive research on. And then we changed the background strain of the mice. And this is not novel. Other fields have done it. And all of a sudden, with the exact same mouse mutation, we had towards the most severe end of the human spectrum. And so it dramatically altered the severity of the phenotype and the death of the mice. They were dying from dissection, which they weren't before. And so we applied that to the eyes as well. And we found that those different backgrounds have a substantial effect on the eye phenotype in the mice too. So I think I don't disagree with Dr. Warner and Dr. Kuchny. I think it's true in many aspects of mouse eye research. But I think a real comprehensive analysis of, have different factors been considered that may be playing a role. I think that's at least worth exploring before we definitely rule out that the mice don't show something. To the point where, the milder background strain in the cardiovascular phenotype doesn't show a significant difference in axial myopia, for example. So if I'd have just done that 10 years ago when I started, I'd have probably dismissed that model. And instead, we've used that now to do several therapeutic studies, and the mice actually recapitulate some of what's seen in humans as well. So I wouldn't totally rule that out at this point, I think would be my thought with that. There was one other thing I was going to mention earlier that we moved on from, about Dr. Warner's comment about longitudinal follow-up, which I totally agree, absolutely critical in patients, but challenging. Given that we came to you through the Marfan Foundation, you all obviously know about their conference that they run each year, and the clinic that they offer there, where patients can be seen. I don't know for disorders that are so rare that it's hard to have a single fixed base. Maybe that is the best method. I don't know. Alternatively, if there is a conference each year, and whether it makes sense to have patients come, every third year or something, wherever that is, to get a standard set of testing, such that you have, longer term follow-up. I totally agree with Dr. Warner. I think that's really essential for understanding a lot of these disorders.
Yeah, agree. If I may go back to the mouse model, you said that there is a modification of the background. Do you mean that they were humanized? Sorry, excuse me for my ignorance. There are humanized mice in different aspects?
No, not at all. I wasn't sure how best to put it. The way I normally explain it to families and colleagues who are not familiar is, we're all very familiar with different pedigree dogs. So a Chihuahua versus a Doberman, and they've all been inbred so long to generate what are considered the classic features of that particular inbred pure pedigree dog. And so there are essentially lines of mice that have that same history of inbreeding. So it was a very wealthy family from Maine. I actually don't even know how long ago, a century or two ago, that started actually taking mice and keeping them inbred and separate from ever breeding them between each other. And so there's many different, what we call strains of mice, but it's really essentially pedigree lines of mice that are genetically inbred over decades and decades, if not centuries. And so whilst they are all mice, they have genetic distinctions that there are external characteristics such as coat color, that's an obvious one, but they actually carry different variants in other genes that can significantly influence the severity of the disorder that you're looking at. And we have a strong interest in our work in what we call modifier genes. So second or third or fourth genes that actually impact the severity of the disease that the patient has. And we certainly now have pretty clear evidence that these other genes can impact the severity of the disease far more than the primary mutation in the original gene. You have to have that mutation, obviously, to have the disorder, but the actual severity of it is dramatically influenced both in mice, and now we have evidence in humans by these other genes. So, and sometimes that's honestly a little bit of luck. What background did one start on? Did you get lucky to pick a background that has a variant in a gene that helps you or hinders you?
Okay, so you've been comparing like CD57 to other type of mice or this kind of things. Okay.
Yeah, we have a multi-year project currently under review that hopefully will be out soon that I would be happy to share, that actually ties in with a human study that we did in parallel. And we now have evidence of another background as well that dramatically influence it. So yes, I'd certainly be happy to share any stuff that comes out.
So going to the, well, we are already well advancing the time, going to the technical challenges. So do you have any really technical issues that blocks the research now in ophthalmology, in this particular type of ophthalmology, or do you have enough with all the procedure that I try to list here? And do you think a combination of the procedure, I think Dr. Warner could answer that, or mixing small molecules such as protease inhibitors combined with some procedures, or should we focus on stem cells implantation? What technology issue would be the first one that you would address? Dr. Warner?
So this is a really interesting question. So I am not an expert in all of the treatment modalities you have listed here. And in fact, I don't even perform cross-linking currently, but so for the ATS patients I've seen who have needed cross-linking, we have referred them to someone who can perform that. But I think that after you characterize the disorder and you understand the potential for the therapeutics, then that naturally will lend itself to a certain treatment modality. So, for example, once we are able to determine the ratio of proteins, for example, in an ATS cornea, and we understand whether or not the building blocks for successful cross-linking exist, then that in turn becomes the natural treatment modality. And so I think characterizing the disease on a microscopic level is priority number one, and that will inform the correct treatment pathway.
So it's really personalized medicine.
Absolutely, because there's broad heterogeneity just within this rare disorder.
Yeah, if I could echo that, Jeff's point about using mice, in the sense that it's somewhat easier because your genetic background was already well characterized. You can go back to decades, a century, and you have a pure background, so to speak. You can manipulate the strain by breeding them, back crossing, what have you. But in human patients, such a heterogeneous condition, the genetic background, the environmental compounding factors, those are all contributed to the disease severity. If you take the connective tissue disease, that the umbrella diagnosis, Marfan probably is the most common disease, at least for the patient population I have seen. Sticklers probably is somewhat common as well, but nonetheless, even just look at the Marfan patients, you look at the literature, there are they're probably the largest database reported in the ophthalmology literature. It's like over 1,000 patients. It's very difficult to do the genotyping phenotyping correlation. I think largely is because of the nature of a Marfan disease is the fibroin-1 gene is such a large gene. There are just so many mutations, over 3,000 mutations can affect the disease. That is not surprising. There's just such a heterogeneous manifestation. But for the rare diseases that you listed here, I think we just have to do the somewhat, combine the resource using the genetic approach. If you have a genetic diagnosis, and we're pretty good at checking the eyes, whether the patients have a keratoconus is, debatable, but we can, just map the cornea, and it's readily accessible. We can do the just simple biometry measurement of those eyes. If we have the genetic information, I think it gives us it really empowers us to do the deeper dive in terms of correlation between specific genes, specific mutation in that specific gene correlating with a phenotype. I think until you get that clear picture, I don't think you can come up with a one approach to treat all conditions, because it's just so rare. We don't even know the pathogenesis of those diseases. Part of it is just we don't have a clear phenotype. Now the genetic information is just such a powerful tool, and if the genetic folks, if they see the patients with a cardiac manifestation of a connective tissue disease, I think they need to be educated, refer those patients to ophthalmologists to do the complete eye exam. And with all the data and everything is on EMR now, we certainly can go back, even though at the time of your exam, you didn't think keratoconus that much, but the data can be documented, can be reviewed later on.
Now, genotype phenotype agreement, it's extremely difficult, not only in ophthalmology, in many rare diseases, and taking into consideration the modifier genes, that's even with the same mutation, you can have different phenotypes if you include all the modifier genes. So that's it's a real problem in rare diseases. What do you think about the new stem cells transplant and this kind of very personal medicine? Sorry, personalized medicine with the stem cells. Is it something that is somewhere to explore, or that's something you wouldn't go in that direction? If you have any experience, Dr. Dole, Dr.
I'm sorry, do you specifically mean stem cell, the more recent work looking at the use of stem cells for corneal endothelial replacement? Is that
yes?
Is that the reason for your question?
Yeah.
So again, I'm curious to hear what Dr. Warner has to say. My take on that would be, I feel as though for a corneal endothelial disorder, the opportunity to inject cells that coat the inner layer of the cornea and are critical for maintaining its clarity, but not essential for its fundamental structure, seems as though for something like Fuchs endothelial dystrophy, that would seem a good opportunity, because you only really need to replace a single layer of cells that then has to adhere to then essentially pump fluid out of the cornea in order to maintain its clarity. My assumption, and this may be wrong, my assumption would be for stem cells for a cornea that has reduced structural integrity, like keratoconus or keratoglobus. My concern would be that you would have to get the cornea early enough to get the stem cells in to prevent a progression. So probably something more equivalent to a cross-linking approach, where you're really trying to stabilize the cornea and prevent further progression. Could it be feasible potentially? Could you get cells? Could you inject cells in a way that they spread out enough through the whole cornea in the correct layers and integrated into the existing network to prevent that progression? And given that we still don't really know why the keratoconus is occurring, may they then be subjected to the same pathological mechanisms that drove the keratoconus in the first place, and therefore maybe they would succumb to the same thing? They would be some of the concerns I think I would have, but I wouldn't want to say it's not doable. I think there may just be, I don't think we could simply just extrapolate the endothelial progress directly into other layers.
I agree. I think once the structures have developed, then modifying the structures then becomes quite difficult, whereas a single monolayer replacement of tissue is much more feasible. So for connective tissue disorders, where we're talking about modifying a much larger structure that's more biochemically sophisticated, I think that approach becomes much more difficult and maybe less feasible. Now, you could foresee, and there are some ethical concerns surrounding this, but you could foresee a time where maybe a CRISPR technology could perform gene modification at an early enough stage to prevent the development of the disorder. And so that's an interesting therapeutic approach. But again, there's some ethical concerns about how that would be administered and at what stage and for whom, and also the cost of it. So I don't think that stem cell treatment for at least the disorders we're talking about is really as high a priority as looking at other treatment modalities.
So if I understand correctly, it would be almost a pre-symptomatic treatment that would need to be done.
Absolutely, because once the cornea is fully developed, right, and that happens at the beginning of life, right, all of the fundamental building blocks that a cornea develops with are fixed in the beginning. Okay, so we don't know all of the things that causes a cornea to become ectatic, but presumably all of those building blocks, and it is what it is at the point of development, and that happens early in life. And so that's when it makes the most sense to have an intervention that's going to actually modify the structure to such a significant degree. And I'm just not sure, how feasible that is, but that's where I think you could make the biggest impact on on a developmental disorder.
Thank you.
And I think probably realistically that highlights that there's not going to be one modality that achieves this, but probably several, depending on the stage of the disease. Perhaps, stem cells, small molecule, there may be something to prevent progression if picked up early, but you're probably unlikely to get away from transplantation or other mechanisms if it's very advanced before it's actually picked up.
So in fact, the need of early diagnose is fundamental.
Critical.
Critical.
Sure.
Sorry, there's some blank because I'm taking notes. We are arriving at the end of the hour. I don't want to, I don't know, Andrea, if you have any other questions or things you want to address, and have the reflection also of you three ophthalmologists, maybe a kind of conclusion, something you would really want to emphasize on the new need, on the absolute need now to progress in research.
Thank you. First, I think that I hate the fact hearing that we still need more genophenotype even in Marfan, only because they are so much, the patient population is so much higher than an ATS or Milan or FG. I was hoping that maybe they had more of that done, but it sounds like we need to really focus on, as the patient group leaders, educating our families about biobanking if the inevitable were to happen. I had to do this on the fly a few weeks ago, and thank you, Dr. Warner, for getting everything in place if we needed to do that. And of course, we never want to lose any of our patients because they become families to us as well. But we do need to do a better job about having a biobank in place, and maybe a collective connective tissue biobank where we can store all the tissue. I don't know how feasible that would be, but it's something to talk about with other patient group leaders and have more conversations with you guys. There was one thing in the chat that I asked about if there was a safe way to collect samples, and I'm so grateful for the replies that you had given. How hard would it be to biobank fluid from the eye? And so for example, Dr. Warner, would you get enough information from the cells in the eye to tell you what you need to know about the corneas, or Dr. Doyle, about other areas for Marfans that you might see? Would you be able to get the information that you might need from the fluids?
I think that while I would be interested to see the differences in the composition of the aqueous humor, that realistically we actually need the corneal tissue. And that's really assessing the different small molecules that comprise that specific cornea would give much better information.
Thank you.
I think I would say you can probably get some information. It may be, depending on the disorder, depending on exact feature you're wanting to look at, it may range from useful to not useful. So I think as Dr. Critchley had pointed out in the chat, when we go in and remove a lens, for example, from a Marfan patient and take the capsule and then sew a new lens into the eye, you know, there may be an opportunity to keep those tissues and look at them. And I think that probably could, if we could do that in a more systematic way to get what we can, undoubtedly, I think that makes good sense. And I think doing that at a patient group level to try and, so we're all doing it the same and we're collecting tissues in the same way, and therefore when we're trying to interpret what we see, it's consistent. I think that is great. And I think that does make a lot of sense to do. I think you do run the risk of developing some bias in those studies. For example, you know, there's a certain subset of patients that are going to have enough lens dislocation or problems from it to require the surgery, and there are some that are not. And so what you deduce from the tissues of the patients that required the surgery may not necessarily be fully extrapolatable to the other patients that didn't require the surgery, but it's undoubtedly better than nothing. So, for us, for example, when we're looking at, you know, pathological myopic growth, those probably are going to be close to totally uninformative. So I think, whilst I may have a bias, I do think that preclinical models we can't get away from. I think trying to understand mechanisms in preclinical models and then applying what we've learned from that to the human tissues that we can get, whether they're surgical or whether they're autopsy, I think definitely seems to be the best complement of approaches in my mind. if we were being bold, there are a couple of suggestions that I have that I am not aware exist, but I think if we were going to really try to make a concerted effort to impact not only the connective tissue research field, but potentially many other fields. For example, something that doesn't exist as far as I'm aware is a pentacam for preclinical species. And Dr. Warner might correct me if that is true, but being able to develop or having a pentacam machine that's able to perform corneal topography on mice, for example, or on rodents, I think that would be a massive help in more rapid throughput analysis and phenotyping of mouse models that may have something, or it may just be more mild, and because they're not bad enough to manifest such a severe phenotype as the bad humans, it's been missed. But it doesn't mean that we can't learn a lot about the mechanisms even in that. And so I would have said a corneal topography, so a pentacam equivalent for mice. I think another area that really would be of massive benefit, even outside the connective tissue field, is wide field imaging, posterior segment wide field imaging in mice. We have a project going at the moment. Something was attempted 2+ decades ago for a systemic disorder with ocular features, with peripheral retinal degeneration. It's called gyrate atrophy. And really wide field imaging of the retina just transformed how we can phenotype humans and actually now in putting together a human clinical trial, we're at least have access to a technology that simply wasn't available before. If there was interest at a collective level within the ophthalmology world for wide field photography of the posterior pole, wide field fundus autofluorescence, and wide field OCT, I think they are 3 technologies that, if resources and effort were pooled, would benefit so many fields, many connective tissue, Marfan, Stickler, many of them with retinal pathology, but even outside of that, they would be, huge advances in deep phenotyping of models that could potentially supply information for human studies.
Thank you very much.
Fucci, do you have any other suggestion? What do you have any remarks on what Dr. Ball just said?
I cannot agree more than what he just said. For one, my lab could use those things that does require concerted effort. It goes back to the difference between mice and human anatomy. Jeff already mentioned. In mice, the lens is so much bigger, rounder than human patients. So it does require different optics to capture the fundus, to capture the topography of the cornea. So those are not there yet, at least as far as I'm aware of. Rodent OCT has been, was difficult just even 10 years ago. Now it's pretty widely, available to all the research scientists that, you doing different researches in the retina field, in the glaucoma field. It's almost like a standard of care, if you will. So I expect pentacam, wide fundus photo, wide field OCT could be, just like what we have is spectrum domain OCT in mice. Hopefully within the very near future. So I totally agree with Jeff just mentioned. I want to circle back with Jade, just the question in the chat that at what age we need to screen the patients for the eye diseases. I think that the minute, as soon as you have the diagnosis, be it a clinical diagnosis or genetic diagnosis, those patients should be referred to ophthalmologists to get a complete eye exam. At this point, I think we just have to assume all connective tissue diseases have ocular findings. Many of those we don't know until we look. So I think we just have to bank the data as well for the future research. And accordingly, we can, make animal models to knock down the gene, knock in the gene in mice, what have you, and that would help help us to do the deep dive in terms of the molecular mechanisms and for the treatment, be it the stem cells or the CRISPR treatment, what have you.
And if I can add one final point, Rachel, saying that made me think of something. I think one of the challenges I recognized that I actually was a part of the Department of Genetics at Hopkins before I actually transferred over to Wilmer for clinical training in ophthalmology. And I think one of the big challenges I realized from the geneticists was the Eye Institute had 200 faculty, and who on earth was the right person to send a given patient with a specific disorder to? And I found that it was often a challenge for the doctor, the referring physician, the patient, and the receiving physician to get them to the right person. And it sometimes took several visits and a lot of frustration, and sometimes it still didn't happen. So when I went back to Wilmer, we created a genetic eye disease center at Wilmer, really with the goal of streamlining referrals from the different departments across Johns Hopkins actually into a single point source. And we had a coordinator who came on board who is fantastic. And she, working with us, she handles all the referrals and points them to the exact person they need to see, whether it's referral from the community, whether it's from inside Hopkins. And I think that just made the patient experience dramatically more efficient. The doctors were happy because, to Dr. Warner's point, they were at least then seeing all the patients with that disorder, so that gave them higher volume and more experience in it. And it made all the referring physicians much easier too. So we just have a website, a single number, patients, physicians, whoever it is, just call that number. So I don't know if there is a role for encouraging centers who don't have a point person or a point group or some sort of thing as a way of creating a model or encouraging it or supporting some sort of thing at an individual place. I feel like a lot of the time it's political will that is the challenge, and finance. You know, we had a lot of political goodwill to create the center and funding to create a position to help us achieve this goal, but without some sort of financial support or backing for it, it may be difficult for places to do.
We had a similar experience when in Arkansas, we are the flagship institution and the only academic medical center in the state, and the state only has 3,000 people. So we have a large catchment area of referring physicians who simply don't know what to do with their rare disorders. And so we established a genetics clinic within the Jones Eye Institute, much like Dr. Doyle has described, where we see all of these patients. We have a geneticist working alongside an ophthalmologist. There's a coordinator, and if testing is required, they simply explain to the patient what is known, what's available, and what funding they might be able to apply for in order to pay for these tests, which sometimes are quite expensive. And I think that this model absolutely is great for clinicians and patients. But tying this back into our earlier discussion, I think if we could connect all of the centers across the country who do this kind of thing and create a unified approach of collaborators and put all the information in one database, I think we could really, really use that type of data to generate high-powered studies. And so I love the idea of either just connecting electronically or having a recurring conference where scientists, clinicians, and families can attend, and we can talk just like we're talking tonight on a much larger scale with more willing and able people.
I will just add, if I may, I actually have a colleague at Hopkins who's a gastroenterologist who's heading up our precision medicine connective tissue program. And this is an IT-based database that is exactly what Dr. Warner's described. It's a standardized database that can be used across all EPIC systems and all non-EPIC based systems. So he tells me it's compatible with all EMRs, which I'm quite astounded about. So I think if it sounds as though at least us, and I'm sure others, have something already in the works, I know that he would be happy to discuss that further and help expand it if it's of use.
I think this is a great idea, and it goes back. We had a similar conversation with the connective tissue cardiologist about this exact thing, about using, was it word blocking or Armel, what was the correct term for that? But basically they created a certain verbiage when they were putting in the medical records, so that it would flag it about that particular patient. Let's say, for example, if they had genetic testing. I'm a huge advocate on genetic testing. I work in the industry, and I know that that has to be our first tier, is to make sure that everybody is genetically confirmed. But sometimes with Marfan's and all of these other connective tissue disorders, they have some overlapping, phenotypes. And so, that's going to be your first tier. But we also need to be able to look into those EMR systems and tell that they've been genetically tested. So if we could come up with like code words or word phrases that we could put into the EMR system, they are actually going to try it on their own. Maybe Armel can explain that a little bit better. I'm not sure, but
yeah, they need a new coding, an AI algorithm for based on language processing to recognize across the registries the characteristics that can lead to identify more patients and standardize all the data and gather all the data in the same database. Sorry. So that can be done. If it can be done in cardiology, then it can be done also in ophthalmology.
I would also love to learn more about the system that your colleague has created. And I have to say, I'm very grateful for all of you for joining us today. I know that it's after hours and in your personal time, but I feel like we've made great leaps and bounds just by having this conversation. And then what we can take back to our groups, and we'd love to share with you what outcomes that we find because of this.
Sounds wonderful.
That's
Thank you so much.
great conclusions.
Yes, thank you all very much.
Yeah, thank you. And I think it's just the beginning. And we'll go back on all these ideas. And we need to work on them and make things happen.